Bismillah ar-Rahman ar-Rahim. Dear professors, dear chairman, my dear colleagues, it's my great honor to be here in such an elegant conference. My presentation today will be heart rate reduction in hypertension. Is it beneficial, neutral, or harmful? The topic is, we used to know that the heart rate reduction is beneficial on all cardiovascular disease. Why? What is the pivotal role of heart rate in cardiovascular disease? We know that elevated heart rate will increase atherosclerosis by increasing endothelial dysfunction, increasing the oxidative stress, decrease plaque stability, and increase arterial stiffness. At the same time, elevated heart rate will increase the ischemia by a lot of mechanisms like increased oxygen consumption, decreased diastole, and decreased coronary perfusion, and both will lead to remodeling, and it will increase heart rate lead to chronic heart failure. So increase in heart rate, elevated heart rate, will lead a lot of cardiovascular problems. We can see that elevated heart rate will cause vascular damage in the form of atherosclerosis, plaque rupture, increased oxygen demand, and ends by major cardiovascular events in long term. A lot of studies studied the effect of heart rate regarding cardiovascular disease, the resting heart rate, and it was found that the sudden death risk increases progressively with resting heart rate in the general population. We can see that above 75 beats per minute, there is marked increase in the relative risk of sudden cardiac death. Also, the resting heart rate independently predicts total and cardiovascular mortality in men and women. The resting heart rate, all these are studies, predicts survival in people aged above 65 years old. In cases of admission, in case of myocardial infarction, it was found that the heart rate above 100 is associated with marked increase in hospital mortality from the myocardial infarction. And of course, the beautiful study said that the heart rate is a predictor for cardiovascular death. So what about, this is in cardiovascular disease in general, in myocardial infarction, in everything. What about in the hypertension? We know that the hypertension is a widely prevalent major cardiovascular risk factor. The risk factors of development of hypertension we all know is the age, smoking, alcohol, obesity, diabetes, renal damage, and others. But there is another risk factor we always ignore, which is plays a role in the pathogenesis of hypertension, and it's always neglected by us, is the heart rate. Increase in the heart rate is associated with increase in blood pressure. And it was found there is a 3 to 4 times higher risk of hypertension has been reported with increased heart rate after controlling the traditional risk factor. When I control all the previous traditional risk factor like the obesity, diabetes, renal damage, and just making the heart rate is the only variable, we found and there is a 3 to 4 times increase in hypertension in cases of increase in heart rate. And it was found that the heart rate increase in hypertension is associated with adverse cardiovascular outcome. Regarding the factors influencing the cardiovascular risk in patients with hypertension, heart rate above 80 is mentioned in the guidelines. What about in hypertension? What heart rate can do in blood pressure? So, heart rate relation to the peripheral and central blood pressure. Changes in both peripheral and central blood pressure are strongly associated with heart rate. And this relationship is quite complex. The difference between the central and the peripheral blood pressure is about 20 millimeter mercury. With regard to the cardiovascular outcome, the Strong Heart study demonstrated that the central pulse pressure is more strongly associated with vascular hypertrophy, extent of atherosclerosis, and cardiovascular events, and peripheral blood pressure, than peripheral blood pressure. So the central blood pressure plays a role in the pathogenesis, in the effect of outcome of hypertension. We know that the increase in heart rate, it increases the peripheral pressure, but it also reduces the central pressure. These antagonistic effects of heart rate on the two pressures raise the concern with respect of the selection of antihypertensive medications, that when the heart rate increases, it decreases the central pressure, but increases the peripheral pressure, and vice versa, and the opposite. The CAFE study observed significant reduction in the central aortic pressure with amlodipine-based, but not with atenolol-based treatment, despite similar reduction in the brachial pressure. Therefore, differences in central pressure with two treatments could possibly explain the difference in outcome reported in the study. A further analysis from the CAFE data observed that the heart rate has no effect on brachial pressure, but a significant inverse relationship exists between the heart rate and the central pressure. Increase in heart rate decreases the central pressure, decrease in the heart rate increases the central pressure. So, multivariate analysis showed that the heart rate was the major determinant of the central pressure. Thus, the atenolol-based treatment was associated with less effective central pressure reduction relative to decrease in the peripheral resistance. So, this inverse association with the central aortic pressure has been found to be associated with increased risk of cardiovascular events with the use of beta blocker. So, the beta blocker, when it decreases the heart rate, it will increase the peripheral and the peripheral pressure, but at the same time, it will increase the central pressure, which plays a role in the cardiovascular outcome from hypertension. A meta-analysis of randomized controlled trials assessing heart rate changes with the use of beta blocker in hypertension reported increase in risk of all-cause deaths, cardiovascular deaths, myocardial infarction, stroke, or heart failure with lower heart rate in patients of hypertension. So, this is against decrease of the beta blocker in hypertension. That's on. So it's heart rate reduction is not preferred in hypertension. Let's see what is with the resting heart rate and risk of incident hypertension. The question arises whether increase in heart rate increases the risk of incident hypertension. Let's see the BEATS survey, which was done in 2015 on about 4,000 young patients, found that heart rate had significant positive correlation with both systolic and diastolic blood pressure. In Killian cohort study in 2014, studied in patients in a men who having no hypertension. They are about 32,000 patients with no hypertension, no known hypertension. And follow-up 3.5 years found that about 40% developed hypertension. And in analysis of the multivariate stent, there was insignificant increase in the new onset hypertension with the increased resting heart rate is observed. And it was found that increased the resting heart rate by 10 beats per minute increases the hypertension about 8%. So we conclude from this an increase in the resting heart rate is associated with increased risk of incident hypertension, and there is a linear association maybe observed in individuals with heart rate above 80. What about heart rate is a prognostic marker? Evaluation of the Framingham study that by Gleeman suggested association of heart rate with mortality in patients with hypertension not treated with antihypertensive treatment. And each increase in heart rate of 40 beats per minute was associated with nearly 2 times higher risk of all-cause mortality, 1.5 higher risk in cardiovascular mortality, suggesting heart rate is an independent predictor of mortality in hypertension. And we can see how the all-cause mortality in the Framingham study increased progressively with increasing of the heart rate in men with hypertension. Also, the mortality, how the mortality increased with a heart rate increase. So, and the value trial suggested incremental risk of cardiac events with rise of hypertension. In patients with high-risk hypertension, every supplemental increment of 10 beats per minute from baseline was associated with hazard ratio about 1.16 for composite cardiac outcome. Another evaluation of the data from the LIFE study reported 25% increase in the risk of cardiovascular deaths and 27% higher risk of all-cause deaths with each increment in heart rate by 10 beats per minute. And heart rate of 84 beats per minute or more was associated with increased risk of cardiovascular death and all-cause death. So from all the previous, each increase in the blood, in the heart rate is associated with increase of mortality, not only the cardiovascular affection. And similar investigation done in INVEST data showed that the baseline heart rate had a linear association with adverse outcomes in patients of coronary artery disease treated for hypertension. Treatment with atenolol strategy reduced heart rate more than the verapamil strategy with mean heart rate of about 69, respectively, by 24 months. And study concluded that on-treatment heart rate is a better predictor of outcome than the resting heart rate. Yani the patient is on treatment if it is responding to controlling heart rate or not. If the heart rate with treatment is not controlled, this is a bad predictor for outcome. And these analyses highlight the important fact that on-treatment rise in heart rate is predictive of adverse outcomes and should be considered in all patients under treatment of hypertension. This is the INVEST study, and we can see the increase in the adverse outcome with increase of the heart rate above 100. So we conclude from this, the conclusion is the resting heart rate has a linear association with adverse outcome, and each 10 beats per minute increase in the resting heart rate can substantially increase the risk of adverse cardiovascular and mortality outcome, and on-treatment heart rate can provide a better prognostic guide. What about the management of elevated heart rate in the hypertension? We are talking about control heart rate and the heart rate, but what is our target heart rate? This is what is our target. The evidence from either observational or randomized trial suggesting a specific target at which there can be optimal benefit of heart rate lowering in patients with hypertension is lacking. This restricts identifying specific target of heart rate when I can see I'm controlling the heart rate. For using the beta blocker in the Asian population, experts have suggested a target heart rate is less than 70 beats per minute in all hypertensive patients. And by achieving this, by giving high dose of beta blocker, bradycardia and side effects was associated. This is the rule in the newer beta blocker, like the nebivolol, which is preferred as they reduce the heart rate, and also reduces the central and the peripheral pressures. Further, the target heart rate can be lowered less than 65 beats per minute in patients with coexisting coronary artery disease in presence of another comorbidities. It's better to reduce the heart rate, not just to 670 or less. In the analysis of the SHIFT trial in patients with systolic heart failure, sinus rhythm, and heart rate more than 70 beats per minute, on background of beta treatment, ivabradine, in order to reduce the heart rate, was associated with significant reduction of composite primary endpoint, which is the cardiovascular death or heart failure hospitalization, and heart failure hospitalization reduced significantly in the subgroup of no beta blocker and on all patient mortality of target beta blocker dose. So hypertension was accompanied in nearly 2/3 of the patients population in each group. Yani in this trial showed that the patients with systolic heart failure, sinus risk, heart rate 70. In addition, with the beta blocker ivabradine, it improved all the outcome with the ivabradine beta blocker compared to the beta blocker alone. What is the possible benefits with heart rate reduction in hypertension? A meta-analysis done in 2017 reported atenolol to be more beneficial than angiotensin converting enzyme inhibitor in terms of reducing the peripheral diastolic pressure and heart rate in patients with hypertension within the first 3 months of treatment. And another meta-analysis was reported a blood pressure reduction about 10 in the systole and 8 in the diastole, pulse pressure by 2 millimeter and heart rate 11 beat per minute with the use of the beta blocker in hypertension. We all know the Simplicity trial. We know all the Simplicity trial 1 and 2, and it is an interesting analysis of the results of the Simplicity registry, which was done in 2016, observed the renal denervation in uncontrolled hypertension was associated with reduction of heart rate at 12 months of follow-up. And they suggested that the heart rate reduction can be target of renal artery renal denervation, especially for higher heart rate in baseline. So, to use or not to use, to decrease the heart rate or not. Let's take the home message. The resting heart rate is one of the factors found to be associated with incident hypertension. Elevated heart rate is a risk factor and not just a risk indicator. Heart rate in hypertension tends to be elevated, which has been identified as an independent predictor for adverse cardiovascular and mortality outcomes. It can aid in determining the prognosis of patients with hypertension, and use of selective beta-1 blockers is advised in symptomatic cases with elevated heart rate, and thank you.
Thank you very much, Dr. Bassem, for these elegant lectures. So you recommend to reduce the heart rate in hypertension?
Of course.
I want to add a comment. Always the patient with tachycardia and hypertension, more dyspnea. More dyspnea. When I reduce the heart rate in hypertension, the patient markedly improved, because this tachycardia will reduce the diastolic time and elevate endoscopic pressure. Any question?
Thank you very much, Bassem. Heart rate is independent factor انت قلت بالنسبه للهايبرتنشن او للكاردياك ديزيز. طب افرض حد عنده تاكيكارديا صح السؤال وما عندوش هايبرتنشن وزي ثايروتوكسيكوزيس ده البريدكتور بتاعه ان هو هيحصل له هايبرتنشن بعد كده؟
الستادي قالت ان about يعني 3 عملوا about 32,000 patients with not known hypertension. Patients who not known, they were men, and follow-up of 3.5 years, and about 40% of the 32,000 developed hypertension, and they found that the heart rate is a predictor of the hypertension in the 35% of
so
hypertension. I recommend to decrease the heart rate even if the patient is not hypertensive.
Thank you.
Dr. Bassem, you think nebivolol reduce heart rate effectively because it has intrinsic sympathetic activity? Nebivolol effective in reducing heart rate because it has intrinsic sympathetic activity.
Nebivolol, it's a beta blocker, and also it's a vasodilator effect. So this effect differs from the bisoprolol or other beta blockers in decreasing the peripheral by decreasing the heart rate and the central pressure, in controversy with the other beta blockers, which atenolol in the study was done in the cafe, which was found that the atenolol decreased the heart rate, but at the same time increased the central aortic pressure.
Thank you. Okay, thank you, Dr. Bassem.